Today it was not a classic lecture for H. pylori, but about 10 points on some hot issues I will raise now. First of all, we all know that H. pylori has a very bad CV. Helicobacter pylori is the first formally recognized bacterial carcinogen. Also, it is one of the most successful human pathogens, as over half of the world's population is colonized with this gram-negative bacterium. Also, unless treated, colonization usually persists lifelong. H. pylori infection represents a key factor in the etiology of various gastrointestinal diseases, ranging from chronic active gastritis without clinical symptoms to peptic ulceration, gastric adenocarcinoma, associated lymphoid tissue lymphoma. And there is a complex interplay because it's a long-lived bacteria, because there is a complex interplay between the host and the bacterium. We have host immune gene polymorphisms, and the gastric acid secretion largely determine the bacterium's ability to colonize specific niche. Bacterial virulence factors are very important, such as the cytotoxin-associated gene, island-encoded protein CAG-A, and the vacuolating VAC-A aid in this colonization of gastric mucosa and subsequently seem to modulate the human host system. Be aware, this is a very important issue. Colonization with H. pylori is not a disease by itself. It's an important item, but a condition that affects the relative risk of developing various clinical disorders of the upper gastrointestinal tract and possibly the hepatobiliary tract. So, testing for H. pylori, therefore, has no relevance by itself, but should be performed to find the cause of an underlying condition, such as peptic ulcer disease, or for the purpose of disease prevention, such as in subjects with familial gastric cancer. So, you must be justified for testing your patient with H. pylori. In these cases, a positive test result justifies treatment. You must have an underlying condition, you must have a problem to justify testing for H. pylori. May indicate the need to search for other etiologies, and if it is negative, if it's positive, you are justified. And if it is negative, you are also justified to search for another cause. For these reasons, a correct understanding of the clinical course of H. pylori associated disorders and the effect of H. pylori is needed. Here, as we see, we may have pan-gastritis or antral predominant gastritis, and the above one can lead to atrophic gastritis and the gastric cancer, the lower antral predominant to chronic gastritis and peptic ulcer disease. Now, the first critical one and the most famous one. What are the indications to test for and to treat H. pylori infection? There is a fact. Since all patients with a positive test for active infection with H. pylori should be offered the treatment, the critical issue is which patients should be tested for infection. Should I get checked for H. pylori? Screening for H. pylori? Big no. It's not a screening tool. You must have an underlying condition and you are searching for H. pylori. The established indications for the diagnosis and the treatment of H. pylori, let us review it. Active peptic ulcer disease, past history of peptic ulcer disease unless previous cure of H. pylori infection has been documented, low-grade gastric mucosal associated lymphoma, a history of endoscopic resection of early gastric cancer should be tested for H. pylori infection. In patients with uninvestigated dyspepsia who are under the age of 60 years and without alarm features, again, non-endoscopic testing for H. pylori is a consideration. When upper endoscopy is undertaken in patients with dyspepsia, gastric biopsies should be taken to evaluate for H. pylori, and for sure, infected patients should be offered eradication therapy. The question number one, GERD, to test or not to test, that is the question. Patients with typical symptoms of gastroesophageal reflux disease who don't have a history of peptic ulcer disease need not be tested. You are not allowed to routinely test for H. pylori for every patient with GERD. However, for those who are tested and found to be infected, treatment should be offered, acknowledging that effects on GERD symptoms are unpredictable. So the question here, a patient with GERD and someone requests for H. pylori test and it is tested positive, you should give treatment, but you will say to your patient, it will not affect the symptoms of H. pylori. So stop the debate. This is a debatable question and a debatable issue. Now it's not, there is no debate. Therefore, based upon currently available evidence, there is no indication to test a patient with a typical GERD symptom for H. pylori infection unless the patient also has a history of peptic ulcer disease or dyspeptic symptoms. Patients with GERD who are tested for H. pylori for any reason and who are found to be positive should be offered the treatment for the infection, acknowledging that GERD symptoms are unlikely to improve. The debate, again, long-term treatment with PPI in H. pylori, as we know, GERD is a lifelong disease. So most patients will take treatment for a big period or a long time. So long-term, the question here, long-term treatment with PPIs in H. pylori positive individuals with corpus predominant gastritis may promote the development of atrophic gastritis. Here, you are allowed to have a treatment. This is the only debatable issue. Although eradication of the infection before initiating PPI therapy may prevent the progression to atrophic gastritis, still the clinical relevance of this is unclear. The question number 3, many patients took aspirin. What about low-dose aspirin? If a patient is a cardiac patient and having stents, is it recommended for this patient to test? In patients taking long-term low-dose aspirin, testing for H. pylori infection could be considered to reduce the risk of ulcer bleeding. Those who test positive should be offered eradication therapy. What about non-steroidal? Those patients who will take non-steroidal for a long period. Patients, we must differentiate between those already on non-steroidal and those who will initiate non-steroidal. Patients initiating chronic treatment with a non-steroidal anti-inflammatory drug should be tested for H. pylori eradication. Those who test positive should be offered eradication therapy, but the benefits of testing and treating H. pylori in patients already taking non-steroidal remains unclear. We have certain indication for testing and treating H. pylori outside the stomach. Number 1, unexplained iron deficiency anemia. Patients with unexplained iron deficiency anemia, despite an appropriate evaluation, should be tested for H. pylori infection. Those who test positive should be offered the eradication therapy. What about ITP, idiopathic thrombocytopenic purpura? Patients with idiopathic thrombocytopenic purpura should be tested for H. pylori infection. Those who test positive should be offered the eradication therapy. There is insufficient evidence to support routine testing and the treating of H. pylori in, again, asymptomatic individuals with a family history of gastric cancer or patients with lymphocytic gastritis, hyperplastic gastric polyps, and hyperemesis gravidarum. Is there still a role for IgG H. pylori antibody? We all searching for breast test and stool antigen because they indicate active infection, but still a rare group because of the higher pretest probability of infection. Patients with a documented peptic ulcer disease represent a rare group where it is acceptable to utilize an IgG H. pylori antibody test. In most other circumstances where the pretest probability of infection is lower, tests usually which identify active disease are preferred for antibody. Question number 5, what are evidence-based first-line treatment strategies? You must put these facts before choosing the the treatment suitable for first line. Number one, we are dealing with an infectious disease that is typically treated with a combination. Almost, we need a combination of two or three antibiotics along with PPI when concomitantly or sequentially for taken concomitantly or sequentially for periods ranging from 3 to 14 days. In clinical practice, to be careful. In clinical practice, the initial course of eradication therapy heretofore referred as first line. But be careful, therapy generally, first line therapy, generally offers the greatest likelihood of treatment success. So the chances to get out of this bacteria during the first line is great. There is no treatment, you must tell your patient, there is no treatment regimen which guarantees cure of H. pylori infection in 100% patient. And this is a review of the recommended first-line therapies, either clarithromycin triple, bismuth quadruple, concomitant, sequential, hybrid, levofloxacin type, and levofloxacin sequential, and the load. All these has the same, or all these have the same idea of 2 or 3 antibiotics. Number one, before choosing, there are 2 important questions to be asked to your patient. Is there a penicillin allergy? You must ask your patient. Number 2, do you take before previous macrolide exposure for any reason? According to this question, you can stratify and you can choose the antibiotics you will find. If there is penicillin allergy, no penicillin allergy, and no previous macrolide exposure, recommended treatment is bismuth quadruple or concomitant or clarithromycin triple with amoxicillin. Other options, sequential hybrid levofloxacin triple and levofloxacin. I will not go through the details, but all of us know now there are 2 questions. Do you have penicillin allergy or do you use macrolide before? And according to the answer of these 2 questions, you will tailor your patient with a different antibiotic regimen. Today, there is an increasing role of probiotics in first-line therapy. Does it work? Benefits of adding a probiotic as an adjuvant. Emerging evidence suggested an inhibitory effect of lactobacillus and the bifidobacterium species on H. pylori. There may also help to reduce the side effects of eradication therapies and improve the compliance with therapy. A recent meta-analysis of 10 clinical trials of adjuvant probiotics in patients with H. pylori demonstrated increased cure rates with probiotic supplementation. But still important questions in the field of probiotics. What is the optimal dose? What is the time of dosing before, during, or after eradication therapy? And what is the duration of therapy? All these questions are not solved up till now. What factors predict successful eradication? So we are tailoring our treatment according to the area, the environmental conditions, and according to the epidemiological studies. Can we predict the success? Determinants of successful H. pylori eradication is considered, or the most important items, the choice of regimen, the patient's adherence to a multi-drug regimen, frequent side effects, the sensitivity of H. pylori strain to the combination of therapy. Here in Egypt, this is the last epidemiological studies which is working to detect the antimicrobial resistant genes of H. pylori strain to clarithromycin, metronidazole, amoxicillin, tetracycline in Egyptian patients. Here we find that as regard amoxicillin, we have 18.3. As regard the clarithromycin, we have 6.7. As regard tetracycline, we have 1.7. As regard metronidazole, 25%. So we must stick. We have in Egypt now a false idea that clarithromycin resistance is increasing. But as the data coming from this last one, as regard the clarithromycin, it's only 6.7. So it is still working. Also, They studied the resistance rates of H.pylori to combined therapeutic agents in 60 patients infected. Here to the combination therapy, metro and amoxicillin 11.6, metro and clarithromycin 5, clarithromycin and amoxicillin 1.6. It's still working in the Egyptian population. Metro, clarithromycin and amoxicillin 1.6. The question number 7, should we test for treatment success after H.pylori eradication therapy? If your patient is coming to you after taking the course of H.pylori and said to you, it's good, doctor, it's okay, I have no symptoms. You are obliged to test the patient and to be sure that the bacteria is finished or is negative. Whenever H.pylori infection is identified and treated, testing to prove eradication should be performed using a urea press test, fecal antigen test, or biopsy-based testing at least 4 weeks after the completion of antibiotic therapy and after PPI therapy has been withheld for 1 to 2 weeks. However, bleeding peptic ulcers associated with H.pylori modeling studies do support the cost effectiveness of routinely testing to confirm in this case. But in contrast, such a strategy may not be cost effective for uncomplicated duodenal ulcers, even when eradication rates are as low as 70%. What about a debatable subject, patients with functional dyspepsia? In the case of functional dyspepsia, where symptoms usually persist even after successful H.pylori eradication, post-treatment testing can be especially helpful in deciding whenever to pursue alternative diagnoses or empiric therapies aimed at etiologies other than H.pylori infection. It's mandatory. In the 10% of patients with functional dyspepsia who achieve sustained symptom resolution after successful therapy, it could be argued that the benefit of retesting may be outweighed by the onus of retesting an asymptomatic patient or even creating H. pylori neurosis. Respect almost your patient fears. Most of the patient after diagnosis of H. pylori go to Google and he is panic. Patients' own desires on the need to confirm eradication should also be taken into consideration, as their wish to be rid of what is potentially carcinogenic bacterium may ultimately drive shared decision-making in favor of retesting. A final argument in favor of post-treatment testing is to provide data on which to make rational community-based decisions. Without retesting, it is impossible to obtain an information on a practitioner's or community eradication success and on the need to modify antibiotic regimen. Question number 8, when primary therapy fails, what are the options for a salvage therapy? In patients with persistent H. pylori infection, every effort should be made to avoid antibiotics that have been previously taken by the patient, unchanged from previous ACG guidelines. Here are bismuth quadruple therapy, levofloxacin triple regimen, concomitant therapy, rifabutin triple regimen consisting of PPI, amoxicillin, and rifabutin for 10 days, and high-dose dual therapy, amoxicillin and PPI. Again, the last in July 2019, the guidelines from the American Gastroenterological Association recommended bismuth quadruple therapy for first-line treatment, replacing clarithromycin-based triple therapy. Here in Egypt, we don't have this bismuth quadruple therapy. There is consensus for concomitant 4-drug therapies as an alternative, especially when bismuth is not available as in Egypt. This is a simple question, but sometimes it's difficult to be answered. When should penicillin allergy testing be considered in patients with history with H. pylori infection? Mostly it is fake. Most patients with a history of penicillin allergy don't have the penicillin hypersensitivity. After failure of first-line therapy, such patients should be considered for referral for allergy testing, since the vast majority can ultimately be safely given amoxicillin containing salvage regimens. So don't take the history from the patient and stop please refer to an allergy clinic. Numerous studies have documented that although 5 to 10% of the US population state that they are allergic to penicillin, 90% of such patients have negative skin testing and they can tolerate penicillin without hypersensitivity. Referral of these penicillin allergic patients for skin testing will therefore result in most being found to be not truly allergic. After excluding true allergy, they can safely be prescribed amoxicillin-containing salvage regimens as recommended for the non-allergic population. The transmission of H. pylori is very important. Transmission, it is fecal-oral, gastric-oral, oral-oral, through water contamination and may be zoonotic. Risk factors are infected family members, number of siblings, crowding living conditions, clustering in institutions, and poor sanitation. You may be asked, can I catch H. pylori from the work? You can pick up H. pylori infection in several ways. The bug can be in food or water that is handled that is not handled in a clean, safe way. You can get it from mouth-to-mouth contact with someone who has it. Yes, you also can get it if you come into contact with vomiting or feces for someone who is infected. The last question, will H. pylori cause cancer if not treated? And H. pylori infection will not generally be the sole, it will not be the sole cause, but rather a contributing factor alongside family history, obesity, smoking, and a diet rich in salted, smoked, or pickled foods, so it is multifactorial. Stomach cancer is often entirely without symptoms in the early stages, so respect that. Indigestion, heartburn, and loss of appetite are not uncommon. Some important questions. What foods to avoid with H. pylori? Generally, particularly spicy foods, worth limiting or avoiding once an H. pylori infection sits in. Also, foods to avoid with H. pylori. They are simple sugars and the processed foods. Sugar is an ideal environment for the bacteria to thrive and hence should be avoided. Chocolate, dairy, and red meat, processed and fast foods, also excess salt and alcoholic beverages are foods that should be stopped. What food to eat when you have fresh fruits, carrots, spinach, sweet potatoes? What foods also aggregate? Gluten-containing foods may aggravate soy, cow's milk. Again, to test for resistance or to test for virulence factors for H. pylori, up till now, it's not routinely done. Helicobacter pylori virulence factors are not tested as part of a standard H. pylori test, but they are very important when considering whether they are very important when considering whether you need to treat an infection or not. We have the GI map stool test, which it's present in Europe now, which tests for CAG-A, VAC-A. Does the last item, does long-term PPI after H. pylori triple therapy associated with stomach cancer risk? Because long-term use of proton pump inhibitors was associated with a 2.4-fold increase in gastric cancer risk in patients infected with H. pylori who had received eradication therapy, and the risk of gastric cancer increased with PPI dose and duration. A study found, yet an observational study drew no firm conclusions about cause and effect, and proton pump inhibitors are still generally considered safe. What do we need? The last one, the increasing resistance of H. pylori to antibiotic therapy necessitates local availability of the susceptibility tests for individuals and establishment, and this is a stimulus in our country and other countries, and the establishment of regional and the national monitoring programs to develop evidence-based locally relevant eradication strategies. Narrow spectrum antibiotics, which are specific for H. pylori, and the new therapeutic targets could be identified based on genomic, proteomic, and metabolomic analysis of H. pylori. Thank you.